Hi, hope everyone's doing good at this recording. We're going to talk about professional roles in nursing development as it pertains to quality improvement, and is focusing on patient care and safety. Now, I think throughout one of your pediatric lectures, I'm not sure, it might have been, I'm sure that at some point in time that you've heard about the Josie King story. So Josie King, if you haven't heard about it, if Miss Martin did not present it, I highly suggest that you go and check that out, because it's about an 18-month-old child who died of dehydration and a wrongly administered narcotic at Johns Hopkins Hospital. I mean, Hopkins. I'm sorry. I hope that made y'all all laugh right then. Johns Hopkins, it's a pretty renowned hospital. It's not something you would think, oh my gosh, they have a massive error that, an 18-month-old child has died. So, I mean, how did it happen? There were several things at play. Her mother, Sorrel King, tells her the story, and explains how Josie's death spurred her to work on improving patient safety in hospitals everywhere. And you can also find this on the well, we'll talk about that later. I don't want to start in on that at this moment. But go and look at that. If you didn't see that, if y'all didn't watch that, this really talks about quality improvement and patient care safety. So I think you should probably go and look at that. So quality and safety issues. Quality of patient care and patient safety can be compromised because nurses are called upon every day to make rapid and complex decisions. I mean, you're in the room, you have to make a decision right then. If you're not on your A game, you could make a wrong turn there, go down the wrong road and compromise a patient care. The acuity of today's patients and the number of patients who live with multiple chronic medical conditions today usually requires a multidisciplinary approach. I mean, I think we can all agree that I feel like patients get sicker and sicker, and we have to get smarter and smarter to take care of them. Patients place their lives in our hands, trust us to be knowledgeable, trust us to use good judgment when making decisions about their care. Medical errors are the number 3 cause of death in the U.S. today. That's following heart disease and cancer. Now, I didn't add COVID deaths in there yet because, that's kind of up there at this moment in time. But, yeah, medical errors, number 3. Isn't that crazy? It's something that you would not think in today's society and today's, medical advancements that errors would be the number 3 cause of death. There's estimated 44,000 to 98,000 patients that die in the hospital each year as a result of medical errors. Operationally, nurses have a pivotal role in ensuring patient safety and positive patient outcomes. We're right there. We're the ones that are doing it, guys. Okay, so there are forces that drive our rapidly changing healthcare delivery system: economics, societal demographics and diversity, regulation and legislation. Economics, I mean, come on, the cost of medical and pharmacological research keeps going up. There's cost to develop new treatments and technologies, and I mean, overall, the cost of care delivery, it's exponential up there. Other forces that drive our changing healthcare: technology, electronic health records, advancements in patient care delivery, healthcare delivery and practice. We're evidence-based practice. We need to be looking at interprofessional communication and collaboration. We need to be looking at our EBP and determining if we are doing the right things for the patients. Environment and globalization. We're looking at global economy, ease of travel, advances in communication, and multiculturalism. So let's look at our history of quality and safety. Of course, I know our textbooks have to have this, but there's a reason why. The Institute of Medicine, the IOM, chartered in 1970 by our U.S. government, was done to provide unbiased expert health and scientific advice for the purpose of improving people's health. The IOM in 1998 urged healthcare leaders to make urgent changes in the U.S. They wanted to look at quality that can be defined and measured, quality problems they wanted to be addressed that are serious and extensive. Current approaches to quality improvement were just completely inadequate, and that there was an urgent need for rapid change within our whole system as a whole. The statement by the IOM, launched by today's movement to improve quality and safety for the 21st century U.S. healthcare system. Anywhere you go in nursing, anywhere I'm talking about in your education, you will hear the IOM talked about quite often. It is just, I'm gonna take my glasses off. There's such a glare, and I don't want that disturbing y'all. The IOM is very involved, and we are very involved in what the IOM puts out. Anytime that they put a report out, no matter that report, we are paying attention. We are looking at it. We are reading it. For instance, I think when I was in my bachelor's or either my master's, the IOM put out, I think it might have been Healthy People 2020 at that time, or it might have been the last Healthy People one. I don't remember. Please don't shoot me for that. But one of those established that they felt like that we needed to have a large pool of BSN nurses. And so a lot of hospitals then were really pushing for that. They wanted to have most of their nurses who had a BSN. And a lot of facilities have that now. And if a facility can, have a large amount of BSN nurses, then they can also have those BSN nurses who are doing a lot of evidence-based practice for quality improvement. And in doing so, then they become a magnet status hospital, because why? They are invested in EBP. They're invested in quality and safety for patients and for the healthcare needs of those patients. The IOM charged the Committee on the Quality of Healthcare in America to develop a strategy to improve healthcare quality in the coming decade. To Err is Human that was a big pivotal one that they put out. Building a Safer Healthcare System, November of 1999. This quantified unnecessary death in the U.S. healthcare system and placed emphasis on system failures as the foundation for errors and mistakes. According to this report, it is flawed. It is the flawed systems in patient care that often lead to human error. And that human error then leads to those medical errors that are unnecessary. Crossing the quality chasm, a new health system for the 21st century. And this was established in 2001. And y'all will notice that these are pivotal research documents that are put out. So when we say an evidence-based practice, that we want you using documents or research articles that are no older than, I don't know, I think Dr. Palmer does 5 years. If you're in your BSN and your master's, a lot of those will have you do no more than 7 years. It's kind of different. Each program is different. I wouldn't go beyond 7 years unless it was a pivotal thing, such as these that the IOM put out. These were pivotal and monumental to know. The quality chasm, it says the healthcare system is fundamentally flawed, with gaps between actual care and high quality care that can be attributed to growing complexity of science and technology, an increase in chronic conditions, poorly organized delivery systems of care, and constraints on exploiting the revolution in information technology. In 2001, the Joint Commission mandated hospital-wide patient safety standards. In 2003, the JC established the first set of National Patient Safety Goals, NPSG. You can find the National Patient Safety Goals, and these are through Oh, I got to go back to the website. But national patient safety goals are what we look at for deciding what we need to be working towards. We work towards a goal in a care plan. This is the national care plan, basically, the goal set. In 2010, IOM released a report, The Future of Nursing, Leading the Change, Advancing Health. There's our 2010, not 2020, which discussed the role of nursing in the 21st century healthcare. Recognizing the complexities and deficits of the healthcare system, to participate in quality and safety initiatives at the bedside, and to promote quality and safety, patient safety within the healthcare organization. The IOM defines quality, the degree to which health services for individuals and populations increase the likelihood of desired outcomes and are consistent with current and professional knowledge. And this was the IOM in 2001. See, we use these older articles because they were so pivotal for us in healthcare. And maybe y'all are probably listening to this, some of you, and might think, I don't get into it. Y'all, I totally get into quality improvement. I did not think I would until I got into my DNP. And once into my DNP, I fell in love with quality improvement. I would be a quality improvement nurse somewhere if I wasn't teaching. So the 6 primary aims: 1, avoiding patient injuries; 2, avoiding overuse and underuse of services; 3, patient-centered care with respect of patient values; 4, reducing wait times and harmful delays; 5, avoiding waste, energy, equipment, supplies, ideas. Ideas is a waste. If you don't use them, that's a waste. And providing quality of care regardless of the population differences. Okay, so let's talk about the IOM's report to Errors Human again. It categorizes the types of errors. After categorizing the errors, a conclusion that 70% of all errors are preventable. Studying errors and identifying how each occurred also offers data that may be used to help improve the safety for patients. There's 2 types of errors. There's those near-miss errors and adverse events. And then there's 4 types of adverse events. So a near-miss error, let's talk about that. Didn't bring any harm. It was just a mishap. It occurred, but nothing bad or harmful came to the patient. So we can look at, okay, how many of us, and I mean, you're all nurses, you've gone into the patient's room and you're like, oh, come on. How in the world did I only get out 1 of these pills when I should have gotten 4 of these pills out? So believe it or not, that is a near miss error. So it is preventable. It's preventable if we actually read our Pyxis screen and pay attention that we're supposed to give the patient, 60 milligrams, and that's going to be equal to 4 pills. That is a human error that or could have been if we hadn't caught it. Thankfully, things like scanning the medication before we give the pill helps to stop these near-miss errors from happening. So that's what we would term a near-miss error. Adverse events are these are injuries to the patient that caused by a provider of care. So the same medication I just mentioned, instead of listening to the system, you go ahead and give the medication anyway. And it just so happens it does not, he needed the 60 milligrams and we only gave 10 milligrams. I'm just throwing something out there. Or how about we grabbed the wrong pill out of the Pyxis and we scanned the package, and instead of using that as a near miss and saying, whoa, wait a minute, I know I took this out of the right pocket. Okay, so instead of paying attention to that, we just go ahead and okay, we're going to go ahead and give it anyway. Not like any of us, I think, that would actually do that. That would be ridiculous. But there probably are some people out there that would do that. So that same medication, instead of stopping the near miss, they go ahead and give it. And it has a massive interaction with all the other medications the patient is on. So now we have caused harm to that patient. This was still a preventable error. Those 4 types of adverse events: the diagnostic, it's either an error or delay in diagnosis, a failure to employ indicated tests, use of outmoded test or therapy, and failure to act on results of monitoring or testing. Treatment-wise, error in the performance of an operation, procedure, or test, an error in administering the treatment, error in dose or in method of using a drug, avoidable delay in treatment, or in responding to the abnormal test, inappropriate, not indicated care. Preventative, a failure to provide prophylactic treatment, inadequate monitoring or follow-up of that treatment. And then the other adverse event is failure of communication, equipment failure, or either a system failure. So quality in the healthcare system. To achieve quality healthcare, quality improvement activities use evidence-based methods of gathering data and achieving our desired results. Before the 1980s, healthcare institutions focused on quality assurance instead of quality improvement. QA outlined an inspection process to guarantee that hospitals continued to follow minimum standards of patient care quality. QA placed very little emphasis on change or assuming a proactive approach. QI infers a system-wide approach to maintaining quality. The Joint Commission in 2010 identified the core of QI. It's all people should always experience the safest, highest quality, best value healthcare across all settings. QI provides a structured organizational process for involving the healthcare team in planning and executing a continuous flow of improvements so that it can provide quality of care that meets or exceeds expectations. So quality in our healthcare system, using the continuous quality improvement to monitor and evaluate quality of care. We do this to identify areas of concern. So those are our indicators. So we're looking at maybe number of falls, frequency of meta errors, and infection rates. I mean, right now we look at most hospitals look at CAUTI, catheter-associated UTIs, and we also look at when we have the PICC lines or we have central lines, we're looking at those infection rates also. The other things that we look at, I don't know where that came from. Look at are continuously collecting data on these indicators. C, analyzing and evaluating that data. D, implementing needed changes. CQI is used to continuously improve the capability of everyone involved in providing patient care. The tools for tracking these outcomes are often called structured care methodologies, SCMs. This will not be the last time you see this information. These tools are to identify best practices, facilitate standardization of care, and provide a mechanism for variance tracking, quality enhancement, outcomes measured, and outcomes research. We look at guidelines, we look at protocols, it looks at algorithms, it looks at all the standards of care, it looks at critical or clinical pathways, and we're going to start breaking these down. Our guidelines, these are statements to assist healthcare providers and patients in making appropriate healthcare decisions. It's developed by experts and seen as a way to decrease variations in practice. So we're all doing the same thing across the board. Protocols, specific formal documents that outline how a procedure or intervention should be conducted. And so these protocols are used to standardize approaches to achieve desired outcomes, such as chest pain protocol. We see that a lot in our Epic system. There are protocols that you can pull down. Um, there's other systems. I used to take students to Jefferson, and they had a decision tree that was in their system. They didn't use Epic. I can't remember what it was called, but they had a decision tree in there, and you pull that decision tree down, and it listed all of their protocols so that you knew if you had a patient that presented with if they had sepsis, if you suspected that. Then you could pull down that decision tree and look at the protocol. So what am I going to order? What am I going to do? How am I going to take care of this patient to get the ball rolling for them to be well? Algorithms are systematic procedures that follow a logical progression, and it's based on additional information or patient responses to treatment, such as advanced cardiac life support, so or ACLS. Standards of care, often discipline related, and help to operationalize patient care processes. These are set by, for us, American Nurses Association and state boards of nursing. It is also used against us or either for us within litigation. Critical or clinical pathways outlines the expected course of treatment for patients who have similar diagnoses. It's our managed care tool. So, I mean, it's the care plan for what we're going to do to take care of the patient. I feel like you can see those clinical pathways and critical pathways in your textbooks even. You see that those are there. If you have the patient with pneumonia, and it gives you a whole care plan on what you would do to take care of this patient with pneumonia from the beginning to the end. So risk management, this is a very, very important part of CQI. It's a process of identifying, analyzing, treating, and evaluating real and potential hazards. Joint Commission recommends the integration of a quality control risk management program to maintain continuous feedback and communication. Organizations must plan proactively to identify real or potential exposures that might threaten patient safety. The legal responsibility of the nurse is to report these adverse incidents to the risk manager according to the institution's policies and procedures. Attention to employee wellness and injury prevention is that's looking at risk management there. Risk events are categorized according to severity. So service occurrence, serious incident, and sentinel events. We're going to look at some of these. Service occurrence does not result in clinically significant interruption of services. It's without apparent patient or employee injury. It's minor property or equipment damage, unsatisfactory provision of patient care, and most of these are addressed within the patient complaint process. B, a serious incident results in a clinically significant interruption of therapy or service, minor injury to the patient or employee, and significant loss or damage of equipment or property. Minor injuries are usually defined as needing medical intervention outside of the hospital, admission, or physical or psychological damage. Sentinel events, we hear about sentinel events quite often, especially if you work in a facility where Joint Commission it comes around. Sentinel events are a big thing that they they look at all of this risk management stuff, but you do hear about sentinel events quite often with Joint Commission. It's unexpected occurrence involving death or serious permanent physical or psychological injury. These events signal the need for immediate investigation and response. So see, this is why we see this, because right there, that something happened. So we have to immediately launch that investigation into why this happened. These events are subject to the Joint Commission review. So the unanticipated death or major permanent loss of function that is not related to the natural course of the patient's illness or underlying condition. Suicide of a patient in a setting where the patient receives around-the-clock care. Infant abduction or discharge to the wrong family. I can't even think about that one. I can't even think about any of these, honestly. Rape, hemolytic transfusion reactions, wrong patient, or wrong body part surgeries. Common risk areas in nursing, um, medication errors, documentation errors and or omissions, failure to perform nursing care or treatments correctly, errors in patient safety that results in falls, failure to communicate significant data to patients and other providers. Adhering to standards of care and exercising the amount of care that a reasonable nurse would demonstrate under the same circumstances will protect you. Hopefully, should protect you, the nurse, from litigation. So when an incident occurs, our first goal, we're going to start from the top and work our way down. Patient safety. The second, complete the incident report. It's not a permanent part of the chart, but the report can be subpoenaed. C, we're going to look at doing an incident report that's used to collect and analyze data for determination of future risk. Report should be accurate, factual, objective, and complete. Nurses should remain educated and informed and become actively involved in understanding and identifying potential risk for their patients. Ignorant of the law is not an excuse. Maintain a knowledgeable, professional, and caring nurse-patient relationship. So I have one for you. I had an incident where I was the charge nurse on the unit. I was also taking care of doing primary care on 6 patients that day. And this was admitting surgeries, discharging patients, and taking care of the patients that I currently had there. You know, the hospital's always great about pulling your help. That you don't need that IA there. You've got another nurse working, and you both have 2 CNAs working the floor. You don't need that. You know, that's not necessary. So we pull our IA. Well, a physician comes around, reads a chart, takes it, and that was back when we had charts where the sheets were folded over if there was a new order, and physicians will pull them down off the rack, look at them, read them. They might write orders in there as well as what the other physician had written to kind of piggyback onto that, their own orders, and then that was again round table thing. So when at that point when there were orders to be done, the charts went into a special place. When there was nothing to be done and it was shown as, signed off, nothing to look for, then those orders or those charts were put in another place. Oh, so when the docs came around, they pulled my IA. He or she found my chart, pulled it down off of the rack that was I need to order, place some orders for a patient, and I needed to sign off on orders. And I'm like, I didn't see any charts up there. I thought I had everything done until about 5 o'clock that evening, when the patient's husband, who is a physician, came out of a room and wanted to talk to me and wanted to know exactly where when his wife was getting her procedure or test done. I can't even remember which one it was. And I was stood there with a dumbfounded look. What? Wait, what? What are we talking about? I didn't ever see something like that. So I went and I pulled the patient's chart out, and there it was, plain as day. Another physician came in and wrote something right up underneath them, and instead of putting it in the right hole, they put it up as done and accurate and complete. So I had to write up this, and he asked me not to because I had been taking, as his words, not my own, such good care of them through the day. But I couldn't do that. I had to be honest. This was a failure on my part as a nurse. Um, so I had to write this up. I had a big long report to write up. She needed this test done. I can't even remember what it was, but I know she needed it. And I know why I found it. It's because I called down to procedures to find out when they were planning on coming to get this patient, and they had no idea that there was anything actually ordered. So, um, we have to, and I'm glad now that we have, and this is one of those quality improvement things for me, in my opinion. Some people like the paper chart still. I'm good with everything on Epic, because then it remains flagged for you on Epic, and you know that you need to sign off on it. Well, if doctors would sign things and then put your flagged uh, chart back up, then you might not know until me, like the end of the day at 5 o'clock. So there's a quality improvement measure right there, a risk management thing. I mean, everything. We're looking at all encompassing. We missed. We caused almost potential. It was a near miss. The patient did not have any real harm that came to her, but in, with this way of doing things, orders were missed often, and patients were put at risk. So it was great having Epic come in, because now we don't have these types of near misses or any adverse events that happen by missing those orders because somebody came in and did things that they shouldn't have done with your chart. Medical errors account for approximately 40,000 to 100,000 deaths per year. These errors include medication errors, patient falls, handoff errors, diagnostic and surgical errors, and healthcare acquired, so the nosocomial infections. The IOM indicates that 1.5 million adverse drug events occur annually in the U.S. HAIs result in death, increased financial costs, extended hospital stays, and most common HAIs are urinary tract infections, surgical site infections, pneumonia, and bacteremia. Injuries from falls are associated with an increase in mortality and extended length of service, and a decrease in the ability to return to previous health status. Handoff errors involve a break in the continuity of care. Approximately 40 to 80,000 deaths per year occur due to diagnostic errors. Okay, so let's look at the types of medical errors that we can see out there. Our skill-based errors, when slips or lapses in actions taken by the provider are not what was intended, then that's how we get these skill-based errors. Rule-based errors, when a standard or rule is violated. Near misses, an error or mishap that results in no harm or very minimal to patient harm. Some of these kind of go over what we've already been over. Adverse events, accidents, and then the medication error. Preventing those, to achieve safe patient care, a culture of safety must exist. We're going to talk about a culture of safety in, I think it's my Organizations and Power lecture that's coming up here very soon. So every hospital that you go to, any facility actually, it doesn't have to be a hospital. It can be just a doctor's office. They should have a culture of safety. Safety for the patient should be a top priority, but safety for their staff as well. We want to develop that culture of safety, a blame-free environment in which reporting of errors is promoted and rewarded. And also, when we have an error, the reason why we want to make sure that they are reported is so that we can look at improving that care. We can look at QI. We can look at seeing what we could do to prevent it from happening again. When a culture of safety exists, individual providers do not fear reprisal and are not blamed for identifying and reporting those errors. A culture of safety promotes trust. It also promotes honesty, openness, and transparency. These reports are necessary so that the data can be collected and improvements can be made. FDA mandates reporting of serious harm or death related to drugs and medical services. Joint Commission relies on root cause analysis from each Sentinel event. Remember, we talked about that risk management thing? So with the Joint Commission, when we have a Sentinel event that happens, we need to go all the way back. We're going to look at the root cause of why this happened. We're going to go back to the beginning and we're going to investigate it from there, and we're going to find out where exactly that the lapse came in. And this also root cause analysis helps us to learn from the consequences. Several government agencies oversee regulations, licensure, mandatory reporting, including the Centers for Medicare and Medicaid Services. We'll talk about them, I think, almost to the end here, which we are. So based upon those medical errors that we've had, errors in patient care, errors that nurses have done, all of these different things, the changes in healthcare that have been done to promote quality and patient safety, and this is within, I don't know how long Pyxis has been around. I knew Pyxis when I got into nursing 20 years ago. But some of these things, the barcoding of the medications, the bedside handoff shift reports, those things have been within the past 10 years. Computerized documentation, that's been since the Obama administration with the Affordable Care Act. We started doing computerized documentation, but it wasn't mandatory. But once the Affordable Care Act kicked in, if hospitals went to utilizing these types of systems, some type of system where people down in the Delta could have their records, up here in the heart of Central Arkansas, that just a few strokes of the fingers that the physician could find out what exactly had been going on from the primary care. Well, everything gets kickbacks, guys. So they get kickbacks for this. Patient hourly rounding, that came within the past 10 years. Interprofessional communication and collaboration, and the timeout procedure. If you look at the IHI, and the IHI is it's a .org. It's the Institute of Health. I'm sorry, I had to pause that for just a second. I don't want to start it over. So that cut off in the middle of what I was telling you. The Institute for Healthcare Improvement, the IHI.org. You will see a lot of this stuff on there. You will see some other things of time management, but time waster stuff that you can utilize for quality improvement. Okay, so there are federal and state level government agencies that provide tools and resources for improving quality and safety within the U.S. healthcare system. They also oversee regulation, licensure, and both mandatory and voluntary reporting programs. Of course, the chief agency we have in the U.S. is the U.S. Department of Health and Human Services, the HHS. It is for the protection of all Americans. HHS also administers for the Centers for Medicare, administrates, I guess is what I should say, for the Centers of Medicare and Medicaid Services and the Medicare Quality Improvement Organization. They also have, these government agencies have some initiatives out here. The current initiatives from the Medicare Quality Improvement Organizations is the MedQIC, which is a community-based QI program that provides tools and resources to encourage changes in process, structures, and behaviors within the healthcare community. There's also the Post-Acute Care Reform Plan. CMS is examining post-acute care transfers with the aim of reducing care fragmentation and unsafe transitions. Development of quality indicators for inpatient rehab facilities. Hospital quality initiatives. These are major initiatives aimed at improving quality of care at the provider and organization level. Uses a uniform set of quality measurements by which consumers can compare organizations and by which organizations can benchmark their progress. And you can go and do this. Any organization can, or any of us. You can go to the hospitalcompare.hhs.gov and you can look at data comparison of what one hospital to the next. Of course, organizations who participate are offered an increase in reimbursement. You know, money speaks. They'll do anything for because money speaks. I'm sorry, maybe I shouldn't have said that, but I guess we're the same way. If you're offered an incentive package for taking a position in med surge of $5,500, or you can go and that's a 2-year, they'll give you, do it for 2 years. You sign up for 2 years to work. $5,500 is yours. You need that $5,500. You want that $5,500. You're gonna do whatever it takes to get that $5,500. So you're gonna work on med surg for a while, even though your dream job may be to work labor and delivery, and you want to get there and get there eventually. So, I mean, it's really all depends. You weigh out the cost. So everything, the reimbursement that you get for doing the things that you might not like, might outweigh, the yuck about it. I don't know if I said that right, but you know what I'm talking about. So then we have the Agency for Healthcare Quality, the AHRQ. This is a federal agency charged with improving the quality, safety, and efficiency and effectiveness of healthcare for all Americans. Initiative currently underway for the AHRQ is for Health IT, National Quality Measures Clearinghouse, medical errors and patient safety. And then you have the quality indicators. Health IT, guys, is a big area. I've said before, and I mean, nursing informatics is a big thing. It is a big thing. If you want to take the opportunity to go through what all it takes to become an informatics nurse, then you should probably look into it. They're short on the amount of people that are doing it, and they really need some IT people that are nurses that can do that job. So your responsibility as a professional RN is to be aware of the presence of these agencies, understand their importance, and participate in your facility's safety and quality initiatives. We are key to improving patient safety. There's just no doubt about that, right? The IOM's report of the future of nursing leading change focused on these core concepts to help for nurses to help improve patient safety. That's nursing education, that's the research, and that's leadership. Core competencies for health professionals are outlined by the IOM: provide patient-centered care, work in interprofessional teams, employ evidence-based practice, apply QI, and utilize informatics. Patient-centered care: identify, respect, and care about patients' differences, their values, preferences, and express needs. Relieve pain and suffering. Coordinate continuous care. Listen to and clearly inform, communicate with, and educate your patients. Share decision-making and management, and continuously advocate disease prevention, wellness, and promotion of healthy lifestyles, including a focus on population health. Population health is big right now. I mean, we have so many people out there in the public that they just, we take it for granted that they know, they understand, but they don't. We need to teach them. When we're talking about working in interprofessional teams, we have to cooperate, collaborate, communicate, and integrate care teams to ensure that the care is continuous and it is reliable. Employ evidence-based practice. Integrate best research with clinical expertise, patient values for optimal care, and participate in learning and research activities to the extent feasible. Apply your QI. Identify errors, hazards in care, understand and implement basic safety design principles such as standardization and simplification. Continually understand and measure quality of care in terms of the structure, the process, and outcomes in relation to patient and community needs. You can do this as an entry-level nurse. You know why? Because we've already talked to y'all about care plans. You've done care plans out the wazoo. You've done concept maps. To me, it's not any different when you see a problem that you look at it and you think, in terms of a nurse, how would I go about fixing this? Design and test interventions to change processes and systems of care with the objective of improving quality. Utilize informatics, communicate, manage knowledge, mitigate the error, and support decision making using information technology. I am not trying to make you massive quality improvement nurses. If I were, then we would have went much more in depth into QI. This is just a skim the surface lecture because wow, again, I've said this before, we are at this school trying to provide you a base to stand on. I want you to stand on this base. I've given you a little tiny quality improvement base, and then you can expand that base, maybe pour you a few extra squares around there, build on that base in nursing. So focusing on quality of care reduces cost, it increases satisfaction, and improves patient outcomes. Nurses are in a unique position to affect both the patient experience and clinical outcomes by ensuring that delivery of care is patient-centered, that it's safe, and of the highest quality. Learn the organization's QI plan and initiatives. Understand the causes of medical errors, and be a leader. Participate on committees to affect positive change. I want you to be able to be in there creating policies that promote safe, high quality care. Look, I think that you guys are in a unique position because you're going to be graduating from this program. You're going to be getting out there. You're going to be working. You're probably leaving the facility that you've been working in as an LPN, and that's okay. So you're going to be working as an RN in another facility. You've seen things here, you've seen things there, you've seen things another place. I think if you note something that could do with some improvement when it comes to care of the patient, just because you've been to so many different areas, I feel like that you guys are in a great place to be able to implement things that are of great assistance. So that's the end of my report. I'm a little tired. That's the end of my lecture, and I hope that y'all have all taken the time to listen to this.